Please join me in welcoming back Dr. Kathy Baldridge. She'll be doing a presentation on non-opioid pain management, and welcome back.
Thank you again. So I told her not to read all that big long thing again. I don't want to start off feeling exhausted, but I will tell you a little bit of background about my pain management days. And so again, it's one of those instances where I didn't know how to say no. And it was really early in my nursing career, and I was working for a teaching hospital. It was part of the state hospital system in Louisiana, and that was in the 90s, early 90s, and HIV was a big component of everybody that we took care of at that point, because, you know, it really just came on the scene, and managing that was very difficult. And then the medical director that we had of the hospital wrote a grant, and she was able to get some PCA pumps for this state hospital. But they needed some nurses to be trained in that to be able to train everybody else. And I don't know why they chose me, really, other than I was loud and I was very much a patient advocate. And so, like, everybody in that hospital knew my name because I advocated so well and so loudly for my patients. And so I don't know if that's why they did it or not, but that's what I blame it on. And so they sent me for some training in pain management, and I loved it. I loved helping people be appropriately managed for pain. Then I went to work for this long-term care facility for people with intellectual and developmental disabilities, and a position came open about 3 months after I was there because they wanted to start a pain management program. Well, I'd only been there for about 3 months, and so I didn't think that they would really hire me. Surely there was somebody else on the scene that had experience and had been there for longer, and again, it was a state facility, but someone encouraged me, and I applied, and I got it. And so I started the pain management program there. Through that, I decided to become certified in pain management, and there was the American Academy of Pain Management at that time, which changed to the American Institute of Pain Management, and everybody took the same certification exam. Physicians, pharmacists, whoever wanted to become certified took the same one. So when I went to do that, it was in Reno, Nevada, and out of casino, of course. And I got there on a Tuesday. I tested on a Wednesday. When I got there on that Tuesday, they had been having a Harley-Davidson convention. So there were all these bikers that were everywhere. On Wednesday afternoon, all of the cowboys started arriving because they were having a rodeo. So you had this great mixture of people. I didn't know too much about this pain society, but let me tell you what, it was all the way from the researchers that were researching anything about pain, including medical marijuana and, you know, if that would be beneficial, all the way down to Reiki, the people that did Reiki. So it was this vast array of professionals. And it was one of the most interesting things. So I would go up to this little restaurant every night that had this eating area that overlooked the floor of the casino and watch all this intermixture of people. It was exciting. So I did pass the certification exam, became certified in pain management, and it has been a love of mine for a long time, including today in primary care. But what we're going to talk about is the non-opioid management of pain. Because I don't know if you know it or not, but we have an opioid epidemic. Don't know if you've heard that. So it's a problem. Do you think that maybe that kind of came about when pain became the fifth vital sign? Maybe. So sometimes hindsight's 20/20. What we think we put in place to be a good thing may actually turn out to be a bad thing. I don't think assessing pain as the fifth vital sign is a bad thing. I do think it needs to be assessed. What I think is that we weren't appropriately educated in what to do with that assessment when we did it. So here's my objectives. Again, I'm not going to read those to you. I have nothing to disclose. I'm not being paid by any of the pharmaceutical companies that we talked about. I love this statement, not just for pain management, but for everything that we do. And you'll hear every talk that I give, I'm going to talk about assessing the patient, and I'm going to talk about educating the patient, because I feel like that is one of the most important things we do. And I think that's what sets us aside as advanced practice providers, because we do that, because we do focus on that. And everything else that we do hinges on how well we do that. So cure sometimes, right? Treat often, but comfort always. So that is underlying, and especially in pain management. So, like I said, assessment is very important, and there's multiple different assessment tools that you can use depending on the patient that's sitting in front of you. 0 to 10 assessment scale is the one that we commonly use. The nurse or whoever your intake person is will sometimes do that because it is built into the EHR system. But we need to address that even further if the patient is there for anything related to pain. So there's some other pain assessment scales out there that I want to tell you about that you might not know about. This one is the Defense and Veterans Pain Rating Scale. And so it's really small, and I can't really read it all down there, but you have it on your slide. What I want you to know about specifically is those questions that are on the right-hand side of that screen. So I don't care if you're assessing a veteran or who you're assessing. Those are good questions to ask, good questions to know about when you're assessing this patient, and it doesn't matter what their diagnosis is. And document that, because again, just like in migraines, what is it going to do? It's going to help you reevaluate that patient when they come back in. And that's going to give you a much better indicator of, okay, it was 8 when they were here before, and now it's a 4. Because now you know not just about the level of their pain, but how it's impacting their quality of life. Because if there's not an impact on their quality of life, chances are they're not going to be there to see you. People show up when something starts interfering with how they live and their ability to manage their daily life and the things that they like to do. Sometimes the things that they want to do, or sometimes the things that they need to do. So we need to go to work because I like to have the lights on, right? So it's motivators. What's motivating you to do what you need to do? So this one is a pain assessment and advanced dementia scale. So even patients that can't say, my pain is 8 out of 10, there are assessment tools out there. There are assessment tools to use with people with intellectual and developmental disabilities that can't communicate with me effectively. Alzheimer's patients may not be able to communicate with you effectively, but we want to make sure that we provide them with an adequate level of comfort because they can still have a good quality of life. And they still are going to have, some of the conditions that we're going to be concerned about, like arthritis, that we want to make sure that they're appropriately treated for. So look at some of these assessment scales, familiarize yourself with them. Even if you don't use them and you don't document that you use this specific one, it gives you a great idea of the questions that you need to ask to fully assess this patient for pain, which again is going to drive your treatment plan, and it's going to drive your evaluation of that treatment plan to know how you need to adjust it. And it's going to help you educate the patient of some of the modifications that they can do in their daily lives that will help them, because like I told someone earlier, I always tell my patients, I am not in charge of your health. Your health is not my responsibility. Whose responsibility is it? The patient's. They walk around in that body every day. It is their responsibility to take care of their health. And if they're a diabetic, I can prescribe them metformin till the day is long. But if they choose not to go get it from the pharmacy, if they choose not to take it appropriately, if they choose not to follow the guidelines that I'm giving them for dietary, they're in charge. They drive what we do. But they need to understand that. I'm not the driver of that. I am your partner, and I'm going to educate you, and I'm going to help you to the best of my ability. But really, how well you get is dependent on you, not me. So have that conversation early and repeat it often, just so they don't forget. So when we're talking about pain, in Louisiana, and I think we're the only state, we have a restriction on our ability to treat chronic pain. So it is actually written into our rules for APRNs that we cannot treat chronic pain with controlled substances. And I believe we're the only state. So know what your state says for those prescribing rules. But for that, it's important to know what constitutes acute pain, what constitutes chronic pain, and it is all based on time. And you can have chronic pain and have an acute exacerbation of that pain during that process. So that's just a reminder, very basic. But of utmost importance is determining what type of pain you're treating. What is generating that pain? Is it neuropathic pain? Is the pain musculoskeletal? Is it inflammatory? Is it opioid induced? So you want to ask them if they've been getting some opioids from their neighbor or off the street, because that happens a lot, a lot. We have a parish that's near me, and every day, I think somebody's setting these people up because I don't know how those cops are finding that out, but every day there's an arrest of so-and-so that had, 1,000 of this and 1,000 of that. And I'm like, oh my gosh. It's crazy to me, but it's out there. And then it's even scarier for the people that go by this, because now it's all being laced with fentanyl. And so then there are more deaths that are occurring from that than just being addicted to opioids and opioid abuse. So anyway, it's important to determine what's generating that pain, and that's going to drive your treatment plan. So let's talk about different types of those. Neuropathic, something in the central nervous system or the peripheral somatosensory system that has gone awry. And the ones that we're most familiar with is diabetic peripheral neuropathy. Post-herpetic neuralgia is a type of neuropathic pain too. So you want to ask about the historical features. You want to, of course, do a physical exam, and you really do need to use the little stickers, and know which part of the dermatomes are involved, whether it's diabetic neuropathy or neuropathy caused by some other reason. I have a patient who had peripheral neuropathy in both feet. Y'all, I don't know how many times she had been worked up for diabetes because she was overweight. Do you know what her peripheral neuropathy turned out to be? Tarsal tunnel syndrome. So just like carpal tunnel, but in the feet. And so pretty interesting, but the typical things for her didn't work for that neuropathic pain. And that's why it's important to determine your pain generator. So there are some tools to assess neuropathic pain screening. And so I have some of them listed for you there. And I didn't go through all of them, but just to give you some examples. And again, just to know the type of questions you ask, because when patients come in, what do they say? My feet hurt. Okay. So what type of pain is it? Well, I don't know. They just hurt. Okay, well, is it sharp? Mm-hmm. Is it shooting? Mm-hmm. Is it dull? Yep. So they answer yes to everything because they don't know how to describe it. And so these pain assessment tools for the specific conditions will help you kind of drill down so that you'll know, is it indeed neuropathic pain and where is it coming from? And so just a good guide for that. And then we have musculoskeletal pain, which seems pretty easy, right? But it's not really easy because it can be compounded by multiple different things. You can have joint pain, and then you can also have ligament pain, and then you can also have muscular pain, and then if the patient has neuropathy on top of that. And so this seems very linear and very simple when it's presented in this type of format, but we all know that that's not the case because patients are complicated, right? So conditions degenerative joint disease, sprains, strains, tendinitis. And what do people want to do? They want to not move the joint. They don't want to exercise. They don't even want to hear you say the word exercise. But joints are made to move, right? So even if they have osteoarthritis, they need to be at least walking every day. Because what helps support the joints? The muscles. And if you have strong muscles, then your joints are going to be better supported, and that's going to make an impact on your level of pain. But it's so hard to get people motivated to do that. It's hard to motivate myself to do that. I'm like, okay, Kathy, you hadn't closed none of your rings today. Delete the app. I don't delete it, but sometimes I do ignore it. Because it's hard. It's hard to stop what you're doing and invest in yourself. And it's the same for patients. So let them know that you're real and you're human and you have those issues too. But I know that joints are made to move, and I know that if you move every day, then your joints are going to be in a better position. So there are some screening tools for that too. The Oswestry Disability Scale is a good one, and that's the one I'm going to show you. There's also the Roland Morris Disability Scale. So the Oswestry Disability Index, again, is a patient questionnaire. It gives you good information about how disabled that patient is from their condition. So if you have that documented to begin with, and you put your treatment plan in place, then you're going to know how best to evaluate them later. And then there's inflammation. So because we don't move, and because I live in Louisiana, and we like really good food, and we eat rice, and we eat gumbo, and we are all living in a state of inflammation, right? We don't drink enough water. We don't really take care of ourselves. We're stressed, so we have all that oxidative stuff that's building up inside of us. But this is specifically talking about inflammation. And so you think about rheumatoid arthritis, you think about maybe an infected joint like gout. And so you always want to ask about historical features, and then of course do a good physical exam. There are, guess what, some inflammatory screening and assessment tools. So those are listed for you there. The AIMS and the AIMS-2 is probably the one, if you haven't heard about it, it's pretty common to use to assess how much they're hurting in their joints. And so it's a good assessment tool. Fibromyalgia, it's also used for fibromyalgia to assess that type of pain as well. So just some good assessment tools to share with you. Measurement of intermittent and constant osteoarthritis pain, because osteoarthritis is pretty prevalent, and the older you get, the more prevalent it is. And so that's a good one to help you assess that pain, know how best to treat that patient. And then we got to talk about visceral. Visceral is probably the one that I hate the most. And so it's thoracic, abdominal, pelvic. So if you have gallbladder type pain, if you have reflux type pain, irritable bowel, endometriosis, it's all those things that happen on the inside. And sometimes that's very difficult to assess for the patient and get the patient to really narrow down what's happening. But the historical features, what makes it better, what makes it worse, all those things that we learn for pain assessment, that's what you're going to use for that, to assess that and narrow it down well. So then there's mixed type of pains. We talked about migraines this morning. Shingles is a mixed type of pain because you're probably going to have neuropathic pain. And then what else? Inflammatory pain on top of that. So mixed types of pains. Some back pains can be both as well. It's very important in the treatment of pain that you set realistic goals. When you ask the patient, and I know that you all do, right? You ask them, so what level of pain would you like your pain to be at? Do you ask them that question? No. You're supposed to, because that's part of shared decision making. You're supposed to ask them where they would like their level of pain to be. Well, what are they all going to say? 0. I want mine to be a 0 too. Guess what's not realistic? 0. So what we have to teach them is, what level does that pain need to be at so that you can still do the things you need to do, the things you want to do, and the things you like to do. So it really all is about quality of life. That's why those assessment tools are so important, because you really are assessing quality of life. And if they start out where they can't do the things that they want to do at a level 5 and you get it to a level 2, but they're doing those things again, you're successful. You're successful. So just keep that in the back of your mind. So how do we determine treatment? There's some questions that you can use as a guide to go through that. What are the goals of the patient? What therapy options are available? What type of pain it is? Those things that we just talked about. And we're not talking about opioids today, but opioids have their place. They have their place in the management of pain, but we have to use them judiciously, and we have to educate the patients, and we really need to do an assessment of that patient's potential for abuse, which takes some time. And so it's not always feasible when you're trying to see 25 or 30 patients a day. But that's important in knowing, if it is an acute pain syndrome and I can give this patient a couple of days or 3 days. In Louisiana, we have a law that we really shouldn't prescribe more than 7 days of an opioid. And if you do, then you have to have very substantial justification of why you did that. So we're going to talk about NSAIDs again, because they are very effective in the management of pain. Mild to moderate pain is what they're indicated for. Of course, there are potentials for side effects. They are absorbed completely, tightly bound to albumin, just so you can remember some of that pharmacology behind it. And so the mechanism of action of pain, phospholipid from the cell membrane goes down and creates arachidonic acid, and then divides out into prostaglandins. Ooh, Siri's talking to me on my app. Delete her too. And prostaglandins are the drivers behind pain. And so you can see by this on this chart, when I put it in, which nonsteroidal anti-inflammatories work on what pathway. And what you need to know about that is, that's why it's important to know what type of pain and what you're treating. And just because I used this NSAID and it wasn't effective doesn't mean that another NSAID won't be effective. So that just kind of gives you a good idea of which part of the pathway those NSAIDs work in. So there are more than 20 different types of NSAIDs. Did you know that? There's a lot out there. And so I listed the drug class for you, what drugs are included in that class in the second column, and there's a lot. So NSAIDs are very important treatments, non-opioid treatments for the management of pain. So again, I'm not going to go through that whole thing for you, but they all have a little bit different chemical structure. Therefore, their activity is a little bit different. So again, just because one doesn't work or isn't effective for the patient doesn't mean that another won't be. So, of course, we're always concerned about the GI risk of NSAIDs, right? That has almost scared people into paralysis in using nonsteroidal anti-inflammatories to help with pain. Don't be scared into paralysis. Do a good assessment. Do know what the patient's risk factors are. The GI risks are usually associated to the duration of treatment. So if you're on an NSAID for a long period of time, if you have a previous history of a GI event, if you're over the age of 60, if the NSAID dose is pretty high, if you're concurrently using any of those other medications, so you have the drug-drug interactions to be worried about. If they have a history of peptic ulcer disease, we need to test them for H. pylori. Do you know when H. pylori is introduced into the body? As infants, usually. Kind of the same way as like HSV, those sorts of things. So, and it just kind of lives there until you get a little bit older and you're not eating right and your immune system starts to fail, and then bam, before you know it, you have reflux. So everybody that comes in with reflux, do assess them for that. Treat them if appropriate. But you can still treat them with an NSAID. You would want to use probably a coxib for that because they're least likely to cause GI bleeds. And on that previous slide, I gave you the risk reduction factors. So you can see which ones are more prevalent in causing GI risk. And then if they have a high or moderate risk of GI bleed, you can still use them, but you might need to add a PPI. Are there some drugs out there that are combined NSAIDs and PPIs? Yeah, like VIVOMO, VOMO, is that how you say that one? But again, when you combine drugs, what happens? Price goes up. So the cardio risk of NSAIDs, we have to be concerned about that too because we have a high rate of cardiovascular disease in this country. So patient characteristics that make them at high risk are listed on the left there: hypertension, hyperlipidemia, diabetes, smoking. That increases their risk of having a cardiovascular event related to NSAIDs. And so you have to be cautious about that. Now, let's talk about inflammation, because one of the reasons that we treat hyperlipidemia is because they have inflammation living inside their veins, right? So what I use to explain to patients is bad cholesterol versus good cholesterol. LDL is the bad cholesterol. That means low density lipoprotein. So a food that's low dense that they can relate to, cotton candy. Are you tasting it right now? It's the power of persuasion. No, I'm just kidding. So cotton candy traveling through your veins, it really isn't a problem unless the inside of that vein is rough, caused by inflammation. Then it catches and it starts sticking. That's what causes plaque buildup. So, those patients are at risk for an early cardiovascular event. If we add an NSAID on top of that, then that's going to compound it even more. So, and I know this is probably a high-level overview. And then renal failure for patients that take anti-inflammatories, that's probably the least likely to occur. GI and cardiovascular risk are at the top, but this is certainly something to consider if you have a patient that is, kind of borderline renal disease, then I might not consider an anti-inflammatory for them. Certainly not something long-term. They can take it PRN if they need to, but not long-term. And then, there are some drug-drug interactions as well, depending on what their comorbidities are. They might be on diuretics or ACE inhibitors or ARBs that causes further renal function. They are protective up to a certain point. So if we add anti-inflammatories on top of that, it may send us into an acute kidney injury. So just be cautious of those. So how do you know how to choose the appropriate NSAID? Well, you're going to know because I gave you this great little chart. If they have no known risks, short-term, intermittent, naproxen, ibuprofen are good for that. GI risk, consider a COX-2. Cardiovascular risk, it is all associated with increased risk. All of the anti-inflammatories are. So, if you feel like you need one, check that relative risk chart, do it very short term, and get them off of it. If they have renal problems, if you need to check their GFR, if it's less than 30, then I'm probably not going to do an NSAID. Cautious use between 30 and 89. 60 is kind of our cutoff, right? So just be careful, because what patients have osteoarthritis? They're elderly, they're aging, and they have some of these comorbidities anyway. So again, a great chart that has the drugs and then what the potential side effects would be for that. And again, high level, because NSAIDs are everywhere. You can get them over the counter very easily, and patients do, because they're hurting and they need to know how to manage. So what about antidepressants as a treatment, non-opioid treatment for pain? Well, it's pretty good. And especially if pain is impacting that patient's quality of life, because then what happens? They get depressed. because they can't do the things they want to do or the things that they need to do. And so then they have depression, and then it becomes a vicious cycle, and the more depressed they get, the more pain they have. So they can be effective managers of pain to help the patient get back to a good quality of life. So selective norepinephrine reuptake inhibitors. What do you not see up there? SSRIs. They have not been found to be effective, and there have been some trials done, and they just have not been found to have effectiveness in the management of pain or depression related to that pain. So if there's a pain source that's causing the depression, SSRIs are probably not going to be your best option. So are you going to get an SNRI approved by insurance? Well, if you document that it's related to pain, you're more likely to do that. I can't say for 100%, but you are more likely to get it approved if you're using it for a pain management issue, even if there's some depression involved, okay? So, wide range of conditions that may cause chronic pain. Low back pain is probably one of the most prevalent, and those people do have a problem with quality of life because it does affect everything that they try to do, possibly even their job. And they want opioids. Why? Not necessarily because they want to feel good or they want the high off of an opioid, but they know if they take that and they feel a little bit better, then they can go do what they need to do or want to do. But then what happens then? They're feeling good from the opioid, and then they go do something they're not supposed to do and injure their back even further. So we're really not doing any good sometimes by doing that, and it's helpful to educate the patient in that. What about tricyclic antidepressants? Not my favorite. They're not my favorite. They are used for a lot of different things, a lot of off-label things, but they can help sometimes with pain conditions. They are not first line, so I wouldn't even go there first line. And I would certainly consider my patients in that. They can be used, I've seen them used sometimes for diabetic neuropathy if the patient couldn't take gabapentin, couldn't afford Lyrica, and I've seen them used for that, and I don't know. I don't know that they work that well. Patients I find are a little bit sedated sometimes on the tricyclic antidepressants, and so maybe that's why they feel better. I don't know. I just don't find that they're that helpful. But they do have independent analgesic properties. They have been found to have that. And they inhibit the reuptake of norepinephrine and serotonin. So, you know, tricyclic antidepressants have been on the market for a long time for the treatment of depression. What else do they do? Does anybody know the ode to anticholinergics? And it says, "Oh, my meds are making me pink. I cannot sleep, I cannot think. I cannot see, I cannot pee. I cannot spit, I cannot defecate." So they have anticholinergic properties, and they can cause way more side effects, and so they can cause some dizziness, inability to remember things, and all those other things we talked about. So these are tricyclic antidepressants that you most commonly see: nortriptyline, amitriptyline, desipramine. Nortriptyline and amitriptyline are probably the most common. And what is so appealing about amitriptyline, because I see it used a lot, it's cheap. It's cheap. And we know that we have a problem getting things approved sometimes, and so amitriptyline will just be added on, but you have to be cautious about that. You have to be cautious about adding that because, especially in an elderly patient, it is on the Beers list. So selective norepinephrine reuptake, SNRIs, have analgesic qualities. That's why those are approved for the management of pain. And you've probably seen it more frequently with fibromyalgia and Cymbalta, right? So that's where this kind of first came about, of them looking at the SNRIs to see how effective they really are for pain, and how does it help to manage pain? And so then they started digging a little bit deeper into that. And so, you know, same thing, you have to give it a little bit of time to see if it's going to be effective. If it doesn't work, then you need to taper it. Why do we taper SNRIs? Because we don't want to cause a discontinuation syndrome. How do you know when to taper an SNRI? Well, if it's not effective. But, you know, if a patient has been on something for 6 months or a year, I'm likely to taper it. SSRIs too, I'll just throw that in there for free. You need to taper them if they've been on them for a little while. If they got the medication and they didn't start taking it till 2 weeks before they came to see you and they've only been on it 2 weeks, then you're not gonna know if it's effective or not. If they're on it for a really short time, you can probably just discontinue it, but I just don't ever wanna have a problem with a discontinuation syndrome because that can make people feel really bad and cause some really serious, even up to seizures. And so taper them off if it is not effective. So Cymbalta is one of the ones that we think of most. And again, it was initially used for fibromyalgia, but then they found that people that have chronic pain syndromes, whether it be a back pain or whatever the pain syndrome is, that Cymbalta is effective. So it does manage the pain, but it also helps with that depression from the chronic pain. So it's a good use of a drug to try, but you do have to educate patients that first week of therapy, they may see some effect. That's what the books say. I have not seen that. I have to give it 2 or 3, sometimes 4 weeks, and that's what I tell my patients. I haven't seen, they may see a little bit of improvement in the first week, but for the most part, I have to keep them on it for 4 to 6 weeks before they're like, you know what, I think it is. And I had a patient recently who has low back pain. She's had low back pain for a good while, and she went through and got off of all of her opioids. She went through treatment, got off of all the opioids, but she's still hurting. They didn't discharge her on anything. So I said, let's try some Cymbalta and see if that gives you some relief. So I started her on the Cymbalta. I had her follow up in about 4 weeks, and she comes back and I said, well, how's it working? She goes, I don't know. I don't think it's working that good. And I said, okay, well, let's go back and look. So I went back in my assessment and I said, well, last time you were here, you were crying, first of all, because you were in so much pain. And I see a totally different expression on your face today. She goes, well, yeah. I mean, I don't think I'm hurting as bad as I was that visit. I said, okay. So you also told me that, you couldn't work in your garden. You didn't feel like you were doing well with your grandkids when they were around. And she was like, well, I did plant some tomatoes. And so I'm like, okay. So maybe it's working a little bit better than you thought it was. I said, do you want me to increase the dose? Because I start on a low dose, start low, taper slow. And she said, no, I think I'm gonna pay a little bit better attention to how I'm feeling. And let's just leave it here, because maybe I am feeling better. I just didn't realize how better I was feeling. So that's why it's important to do those pain assessments, because they don't even remember sometimes exactly the problems that they told you about the day that you started them on it. So when you remind them of that, they're like, oh, okay, well, maybe I am a little better. So use those pain assessment tools. So you can gradually titrate them up, and if you need to taper them off, then you need to taper them off. Most common side effects kind of looks like the anticholinergic side effects, right? Because it is. It can cause some anticholinergic properties as well. Encourage them to take it on a full stomach. Always, SSRIs, SNRIs, TCAs, whatever kind of antidepressant you're going to put somebody on, never stop the medication abruptly. Scare them so that they don't stop their medication abruptly, because they will have a discontinuation syndrome. So educate about that when you start that, and document that you educated about that. Avoid with other SSRIs, SNRIs, TCAs, because you can cause a serotonin syndrome. Have you ever seen one of those? Those are pretty bad, and they have a high mortality. So I don't want to be responsible for that. It is okay to give Cymbalta with pregabalin and gabapentin if you needed to, so if you had a couple of comorbid conditions there. So let's talk about the anticonvulsants. Again, we have gabapentin, which I said is what? The snake oil of the 21st century. But it does have its uses. Post-herpetic neuralgia, it is off-label, look at that, off-label for the management of neuropathic pain and fibromyalgia. So that means, again, not that you can't do it, but there really aren't studies to support that it's effective. So we have patients on all these medications, and we just keep adding because we're trying to help them. We want to comfort them. But sometimes we might be doing more harm than good. So consider that with gabapentin, because it just is overused. It's not managed. It is not like giving water. You think that because it is not that effective, but it does have side effects. And you hear patients that say, hey, I'm on 12 medications. Can I get off of some of these medications? Well, sure you can, but I'm gonna need you to diet. I'm gonna need you to exercise. But gabapentin might be a good place to start, to taper down, to see, is it really helping the patient, or is it just another one of the medications that are on board? Pregabalin, Lyrica, they're in the same drug class, but it does work better. It's newer, it's a little bit cleaner, and you do get more effectiveness with the Lyrica than you do with gabapentin. So, and you can see it has different indications. It is FDA approved for painful diabetic neuropathy, neuropathic pain, even if it's spinal related, post-herpetic neuralgia, and fibromyalgia. There's been plenty of studies to prove its effectiveness in those conditions. So, it is a controlled substance though, right? And what's the other major difference between gabapentin and pregabalin? Cost. That's one of the reasons you see gabapentin prescribed so much, because it is not as expensive as Lyrica. So you have to consider that with your patients as well. Carbamazepine, Tegretol, we talked about that a little bit earlier, has very limited data for neuropathic pain. It is number one, first line for trigeminal neuralgia. Oxcarbazepine may be an alternative to that. They are kind of in the same drug class. And oxcarbazepine, Trileptal is the other name for that, has been on the market not as long as Tegretol, but it does have some effectiveness if for some reason they were having side effects for the Tegretol. Some of the side effect profile is about the same, but it is a little bit cleaner, so you could consider that if they had a trigeminal neuralgia. So here's a chart for you with the dosages, the characteristics, and I'll talk about some of the trials in there that they've had, if you need to adjust the dose for renal or hepatic use, and then the side effects. And so the biggest complaint that I hear from gabapentin and Lyrica is dizziness or sedation. And so I see patients all the time, they'll come in and they'll be on 100 milligrams of gabapentin 3 times a day. First of all, do you think patients are taking that medication 3 times a day? No. Because the more doses that you get in a 24-hour period, the less likely it is for them to be consistent in taking that medication. So usually when I start patients on this, especially for pain, I will tell them, I'm going to start you on 300 milligrams, and I want you to take it at night before bed. So it'll help you sleep, if nothing else, and we'll get some benefit out of that. Because if patients aren't sleeping, they have more pain. It all ties in together. So, and then I can titrate up from there if I need to. And typically that reduces some of the side effects if you start low and go slow. And then we have some topical and transdermal medications that you can consider. And what are these? Over the counter. So Bengay, Biofreeze, those can be effective for patients in combination usually with other things. And they may say, well, I've already tried that. Well, let's try it again. And let's be more consistent in it, and let's do it with the Cymbalta or with the anti-inflammatory if that's what you're going to put them on. Capsaicin is one of my favorites. Tell them to apply it with gloves, because then what do? They apply it and then they wipe their eyes, or they go to the bathroom and like the hand slides, something, and it burns because it's made out of peppers, right? So, but it is very effective, especially for neuropathic type pain. And then we have topical NSAIDs. Now, topical NSAIDs carry the same black box warning as oral NSAIDs. But what do you think about that? Do you think that's just the FDA being hyper safe? Because you are going to get some absorption from topical, but are you going to get as much of a blood level with a topical as you will with an oral? Probably not. So even with someone that you're concerned with giving oral NSAIDs, then I would consider giving them a topical in combination. And again, it gives them some power, but it's not a one-time thing. You're not going to apply it once and the pain is going to be miraculously gone. So that's where the education comes in. And then lidocaine patches, we know about those too. And they are helpful sometimes for back pain. So sometimes you have to use all of the things that you have in the arsenal. You educate the patient. We talked about trigger injections. You can do that for some of these as well. Joint injections if you needed to. So, you know, there's other things that you can use to develop an effective treatment plan. But the thing about it is, no matter what you use, the patient's expectations is the biggest change of all, because they know what to expect. They don't expect a 0 pain rating. And so that makes all these things that we all know about, and they're very, very common. So I don't think I've enlightened you with a ton of stuff today. But just to remind you that they are effective treatments, but sometimes it's about educating the patient in their expectations in developing that treatment plan to get away from opioids. Muscle relaxants, there's really very little data that they do anything from studies for effectiveness of back pain. But we do know, incidentally, with the patients that we talk to, that sometimes they do help. So that is a potential. Which one up there is a controlled substance? Soma. Very, very highly addictive. I never prescribe it, ever, because it is very highly addictive. But they may be part of your treatment plan depending on what the patient has, if they need some muscle relaxation. So let's just talk a little bit about some of the disease processes. Neuropathic pain, preventative care, what the first line medications are, the adjuvant medications, and then any other therapies that might be beneficial for that patient. But you're always going to start with preventative care and first line. Neuropathic pain, how embarrassing would it be if you assume that it's diabetic neuropathy and the patient really has a B12 deficiency? So assess that for the patient with neuropathic pain. Are they an alcoholic? Do patients ever think they're an alcoholic? So you don't ask them that question, right? You're not going to say, are you an alcoholic? Because what are they going to say? No. Well, how much do you drink? Oh, well, I drink a 6-pack a day. And they're proud. I drink a 6-pack a day. Okay, well, do you ever go a day without drinking a 6-pack? No, why would I? Could you go a day without drinking a 6-pack? Well, no, why would I? Okay, so then we might have to consider that you do have an alcohol problem. So ask those questions in different ways. But assess all the reasons why this patient might have neuropathic pain before you go treating them with gabapentin. If they have a B12 deficiency, we treat the B12 deficiency and they improve. Fibromyalgia, very difficult. Is it real? I hear that question from patients. I think I have fibromyalgia, but do you think that's really real? Okay, well, do you think it's really real? Because if you think it's really real, then I think it's really real. Because sometimes it's about what patients think. And I do think there's a problem. I think that it is a combination of inflammatory and visceral type pains. And that's where your targeted treatments are going to go to. But it's also stress-related. We, at one point, thought it was obesity-related, but there's plenty of women that are their appropriate BMI that have fibromyalgia. Exercise therapy is important. Swimming's important. You can consider a low-dose TCA, depending on the patient's age. You want to make sure that they don't have any problems with that. And SNRI, Cymbalta, is the one that's approved for that. And then maybe consider a muscle relaxant, because we know that getting good sleep is really important from these patients. If they get a good night's sleep, then they can pretty much handle whatever comes their way the next day. And sometimes the muscle relaxants are what help with that. Osteoarthritis, this is kind of backwards. It should be flipped, with mild OA first. Exercise, weight loss, topical capsaicin cream. All of those are very effective for mild OA. But tell patients, this is accumulation, because they're probably, 50, 55 sitting in front of you, maybe a little bit earlier when they come in and complain with that. When did this process start? Probably maybe even in high school if you played softball or basketball or something like that and you weren't very kind to your body. And this is a cumulative effect. So stay on top of this mild, because if you don't, it's going to turn into moderate. And with severe, surgery. But what do surgeons want to do? If you're a 50-year-old, are you going to get a knee joint replacement for OA? Because how long does that knee joint replacement last? About 10 years. And they want to push it and push it and push it as long as possible before they do that replacement. Back pain, and I'm a little bit over. Back pain's hard, but it's not impossible. All of these things are very important on the right side. Limited or no effectiveness glucocorticoids, but what do we see? Medrol dose pack, antidepressants, anti-epileptics, topical agents, herbal therapies. That's just what the studies show. But in combination, NSAIDs, muscle relaxers, and movement, they cannot stay in bed. And they have to make sure that they protect their back if they're going to do anything. So always teach them about all those modifiers, wearing the back brace. Any type of joint pain, I also teach patients about taping. What do we see athletes if they have a shoulder problem? What do we see when they're on the field? Blue tape, because they're supporting that joint. Why can't we do that for our patients? We can. Pull up a YouTube video. I don't usually advise YouTube videos. I mean, don't watch a YouTube video on knee joint injection and then just go do one if that's your first time. However, we can watch YouTube videos and show the patient, this is how I want you to tape the shoulder or your knee, or plantar fasciitis. Taping for plantar fasciitis is very effective. So educate yourselves on some of those things and start helping your patients be educated in them, because that's something really simple to do and very effective that you don't even have to consider medications. Subacute back pain, 4 to 12 weeks. Chronic low back pain, greater than 12 weeks. Back pain, we know if they do all of those things and they move and they stretch and they massage and they take anti-inflammatories, usually in about 6 weeks, unless they have a bulging disc that is compressing on their nerves, they're going to be better. If they're not better, you can justify an MRI. So here's just a little algorithm for you. Heat, stretch, heat, stretch, heat, stretch. And that's what I tell them. Well, it's got a heat, but it should be a stretch. Heat, stretch, heat, stretch. Because that is most effective, and that is determined in the studies as most effective for the management of low back pain. If it is acute, it can turn into chronic. So, and the risk factors are listed for you there. Just for the sake of time, I won't go through those, but you can see them. Those are the risk factors for developing chronic low back pain. And when you're treating acute back pain, assess those risk factors, because you want to make sure that you intervene and educate so that it doesn't turn into a chronic back pain problem. First line is NSAIDs, second line, Cymbalta. Tramadol. Tramadol is a mixed opioid agonist, and it also affects SNRIs, but it can cause some pretty serious, when tramadol first came out, it wasn't a controlled substance. but they found that it did have addictive properties, and so it is a controlled substance now. And then adjuvant would be muscle relaxers, but again, not a lot of therapy. I mean, not a lot of research there to show that those are effective. Therapies that are not recommended. So you can throw them steroids, but it's not recommended, and they have not been found to be effective. And I see that done a lot. Cannabis. Anybody in here can write are you in a state where you can recommend medical marijuana? That's a trend across the United States. There are some states that do allow nurse practitioners to recommend medical marijuana. So you may have a patient coming to you soon that asks you for that. And then opioid prescribing. The prescription drug program is your friend. Use it. I don't know about you, but I am naive, and I believe patients that are sitting in front of me. And so that has made my life a ton easier because I really do want to believe them, but I also want to be a safe prescriber, and I also want to help them if they do have an opioid problem. And so if I see anybody that has a chief complaint of any source of pain whatsoever, before I ever go in that room, I check their prescription monitoring report. And I see what they've gotten, who they've gotten it from, how frequently has it occurred. It also helps me to know if they have a chronic pain problem, which just helps me know how to manage their condition a lot better. So use it, very effective. Thank you. Sorry I went over.
You're fine. Okay, we have a couple of questions here.
Okay.
So the first one is, can you expound more when you said that Florida is one of the 2 states that does not allow APRNs to manage chronic pain with controlled substances?
No, I said Louisiana. Louisiana is one of the only states that I know of that has that rule. I don't know about, I think Louisiana is the only state, and the only reason I know that is because I'm the president of the Nurse Practitioner Association in Louisiana. And so we are working really hard for FPA, and so AANP, I often ask them, okay, well, what do other states do about this? What do other states do about that? And so I think we're the only state that has that requirement. But check your state Board of Nursing rules to know.
Thank you for clarifying. Can you provide information on non-pharmacologic complementary pain management options that you find have been particularly helpful in managing chronic pain patients?
Absolutely. Can I tell you one of the things that I find is patients' attitudes and beliefs about pain. And then you also have to consider culture, and that's a whole nother lecture in and of itself, how those cultures think and feel about pain. But I think the best management of pain starts here, with finding out how that patient perceives pain. What is it about the pain that is so detrimental to them? And if you can help them there and wrap their minds around, especially if it's a chronic condition, that this is a chronic condition. I do have the power to manage that within myself. I can give them tools, and I can tell them about exercise, and I can tell them about an anti-inflammatory diet if they have rheumatoid arthritis, and I have rheumatoid arthritis. And that was one of the first things I did, was say, okay, let me figure out what I can do to help myself. And I should have known. But we don't deal in that a lot. We deal in how to prescribe, what to prescribe, prescribe. So I got on an anti-inflammatory diet myself, and you know what else happened? My IBS was healed. I don't take reflux medications anymore. And my pain, my inflammatory markers when I go see my rheumatologist are normal. They're not elevated. So helping patients be empowered is the #1 tool, and not just with pain, diabetes, hypertension, because a lot of it they can do themselves and get off of some of their medications. It takes longer in an office visit to have those conversations, but it's important.
In acute low back pain with some kidney disease where we need to avoid NSAIDs, are muscle relaxants enough to provide any relief?
Not always. And it depends on the condition. So if they come in and they say, gosh, I was moving the furniture the other day, and oh, I felt it. I felt my back pop, and I haven't been able to straighten up ever since. So probably what that is the piriformis muscle that they strained, which the piriformis muscle, if you've ever looked at anatomy and physiology chart, is stretched tight, almost like a tendon. So it's really easy to strain, especially if you're not paying attention to back mechanics. And when you strain that muscle, it gets inflamed and it swells. And what goes right down beside it? The sciatic nerve. And so when that muscle swells, it pinches that nerve. And so that's why they have back pain. So the swelling is inflammation. And so an anti-inflammatory, and you may want to consider it short term. I mean, if they're, that was a pretty wide range. And that's what the books say, and we're supposed to show evidence. But if I'm not concerned that this NSAID is going to shoot this patient into acute kidney disease, I'll do it short time, because an anti-inflammatory is going to be impactful for that type of condition.
Perfect. Great. Well, that's it. So thank you very much.
Thank y'all.
you again.